I'd like to introduce our next speaker, Morag Taylor. She's a practicing physiotherapist, been so for 15 years, has been working at the Prince of Wales Hospital in Sydney over the last 12 years at the aged care rehab. And she's also been working as a part-time research physiotherapist, and she's done her PhD on falls in cognitively impaired older people, and that's what she will talk to us about today. So, welcome, Morag.
Thanks for the introduction, Kim, and for the opportunity to speak to you today. So, as she said, I'll talk about falls in cognitively impaired older people, and for the purposes of today, I'm going to specifically focus on community-dwelling cognitively impaired older people in the interest of time, but also I'm going to use cognitive impairment sort of interchangeably with dementia, so just keep that in mind for the rest of the talk. So first of all, I'll give a little bit of background. I won't go too much into detail, because thanks to Professor Brodati, he covered some of it. I'll talk a little bit about what formed my PhD, some risk factors for falls in people with dementia. And then I'll talk a little bit about falls prevention in people with dementia, and then a little bit about future research and implications. So as Prof Brodati said, so people with dementia have an increased prevalence of falls, and we know about 30 to 40% of cognitively intact older people fall each year, and in community dwelling cognitively impaired older people this increases to about 60 to 65%, so they have one or more falls during the year. But they also have an increased risk of multiple falls, so 2 or more falls in the year. About 43% have 2 or more falls in a year, and this is compared to about 17 to 22% in cognitively intact older people. And I should just say that in residential care settings, the prevalence of falls is much greater. So in some research conducted by Julie Whitney in the UK, she found that 50% of cognitively impaired older people in nursing homes fell within 6 months. So as Prof Brodati said, injuries are more common, they're more likely to break their hip, they don't regain their function, they're more likely to be placed in residential care, and they have an increased mortality after hip fracture. Central acting medications, Prof Brodati touched on that as well, they're more likely to be on antipsychotics, antidepressants and things like that, and they also have gait impairments, and as he said, there's subtle gait changes that predate the diagnosis of dementia, and there's good literature to support that now. So, as I said, I'll talk a little bit about fall risk factors in cognitively impaired older people, and this is based primarily on the research that we did that formed part of my PhD. So first of all, we wanted to understand why people with cognitive impairment had double the risk of falling compared to cognitively intact older people. So we did a case control study. So we got 138 mild to moderate cognitively impaired older people, and we matched them to 2 cognitively intact older people. And they were matched for age and gender. And then we also followed them up prospectively for a year, looking at how often they fell. And for the cognitively impaired older people, we used the assistance of carers so that we could get more accurate falls data. So the carer had to have a minimum of 3.5 hours contact per week. And what you can see there is what we found is that in the cognitively impaired group, they were significantly worse in their physical and functional performance when compared to their age and gender matched cognitively intact older people. So they had slowed reaction time, weaker quadriceps or knee extension strength. They had impaired balance, so sway on foam. They had impaired functional leaning dynamic balance measured by coordinated stability, and they had poorer functional performance measured by the timed up and go and the 5 repetition sit to stand. You can see for the timed up and go there, it took them 20 seconds to complete in comparison to their age and gender matched counterparts where it took them 10 seconds to complete. And then when we looked at their prospective falls during that 12 months follow-up, so in the cognitively intact group, 45% had 1 fall during that follow-up year, which is higher than what's sometimes reported in the literature, but the cognitively impaired group had 66% of them fell during that follow-up year. And the striking thing here is, as I said, the multiple falls. So only 21% of the cognitively intact had multiple falls compared to 43% of the cognitively impaired older people. So we then wanted to look specifically at the association of some of these potential fall risk factors and see whether they were actually related with falls in cognitively impaired older people, to see whether the risk factors were the same for cognitively impaired and cognitively intact older people, because it has implications for fall prevention trials. So what we did was we did a prospective cohort study, so looking at, we got 177 mild to moderate community and hostel dwelling participants, predominantly community dwelling though, and we followed them up for 12 months. And again, we used the assistance of carers who had a minimum of 3.5 hours contact per week. We used monthly falls calendars and telephone calls to try and get the most accurate data. And we tested them on a range of things at baseline and looked at medical history and so on. But today I'm specifically going to talk about the risk factors that we looked at that are modifiable, and what I mean by that is those that are potentially amenable to a fall prevention intervention. And so the reason I'm going to specifically talk about those is things like previous history of falls we know is a strong predictor of future falls, as Prof Hastorf mentioned this morning, and that's the case for cognitively impaired older people as well. It's a strong predictor of future falls, but it doesn't help us in trying to work out how we can treat or understand fall risk in this group, because we can't change the fact that they've had previous falls. So we had our group of cognitively impaired older people, and we tested all different domains. So we tested psychological impairment, and what I'm going to show you today, these factors have all been significantly associated with falls during the 12 months follow-up when we looked at them in univariate analysis. So when we looked at them individually, they were significantly associated with falls. So we had depressive symptoms measured by the geriatric depression scale, anxiety measured by the Goldberg anxiety scale, and fear of falling measured by the short form FESI. In terms of our sensory motor balance and functional performance, so in terms of the sensory motor performance, hand reaction time, so slow reaction time was significantly associated with an increased falls rate. Static balance measured by sway on foam, and we also did a number of other static balance measures. So we did feet apart, feet together, semi-tandem, near tandem and tandem stance, and nearly all of the balance measures were significantly associated with falls. The only two that weren't were feet apart and feet together, and that's probably because they didn't discriminate well enough between fallers and non-fallers. Leaning balance or functional dynamic balance measured by coordinated stability was significantly associated with falls, and all of the functional mobility tasks, so timed up and go, 5 repetition sit to stand and gait velocity, were all significantly associated with falls. We also looked at various cognitive domains. So we measured processing speed using trials A, trials B, and hand reaction time I've put there because with the hand reaction time task we can't actually delineate between what is a central processing reaction time problem and what is a motor speed problem. Executive function, so Prof Hastorf mentioned this morning that we know that in cognitively intact older people there's a significant association between executive function and falls, and we also found this for our cognitively impaired group of people. And then also for the visuospatial ability, and now this was a subdomain measured by the Addenbrooke's Cognitive Examination Revised, so it's a screening tool that measures various different domains, but this specific domain was significantly associated with falls. Medication use, so again we know that centrally acting medication use increases falls risk in cognitively intact older people, and we also know that cognitively impaired older people have probably been included in those large studies of residential care facilities that have shown an association between centrally acting medication and falls. But this paper is the first one to show as a group of drugs in community dwelling cognitively impaired older people there's a significant association with falls. Unfortunately we didn't find any significant association looking at the different classes of centrally acting medication, so when we looked at antidepressants or antipsychotics separately and things like that. Total number of medications was significantly associated with falls, as was 4 or more. And we also looked at physical activity using the incidental and planned exercise questionnaire. And hours of walking per week, so the more walking people did, that was actually protective for falls. So we then wanted to understand what were the most important factors in increasing the risk of falls in this cognitively impaired group of older people. So we did multivariate analysis where we put a number of different variables in the analysis together to determine which factors were independently associated with falls. And so that we didn't violate the number of predictor or explanatory variables for the population size, we chose one variable from each domain. So for psychological impairment, we chose depressive symptoms, and the way we chose the variable was we chose that was the most strongly associated with falls in the univariate or individual analysis. So we chose depressive symptoms, reaction time was our sensory motor measure, sway on foam was our static balance measure, coordinated stability was our functional dynamic balance measure, executive function measured by trials B was our cognitive measure. Medication use, we looked at centrally acting medication, and physical activity, hours of walking per week was the only component of that was significantly associated with falls. And what we found was the three most important factors in this population was depressive symptoms, static balance, and functional leaning or dynamic balance. And now this has implications for falls prevention, because all of these are potentially amenable to, say, an exercise intervention. There's literature to show that exercise can improve mood in both cognitively intact and cognitively impaired older people, and we know that there's evidence to show that you can improve balance through exercise. What we need to determine is whether improving these things will actually translate into a reduction in falls in cognitively impaired older people. So a little bit about fall prevention in community dwelling cognitively impaired older people. And as Prof Bradati said, there are no trials to show that we can prevent falls, but I'm going to present some of the studies that are out there, and there is limited literature in this area, which is why, as Prof Bradati said, Professor Jackie Close has just got an NMRC grant to conduct a large randomised control trial. So this was the largest and most well-conducted study that there is out there, and it was by Fiona Shaw and colleagues from the UK. And they recruited 274 cognitively impaired older people from the emergency department, and they implemented a multifactorial program that's previously been shown to work in cognitively intact community dwelling older people. But there was no significant improvement in their fall outcomes. But if you have a look in more detail at this study, at the baseline information, you can see there that there was only on average 22% of the population actually living in the community at study entry. So this may have impacted on their findings. It could be that in a residential care setting, you would likely intervene slightly differently to what you would in a community setting. And an example of this is the exercise component of this intervention was a 3-month supervised, individualised exercise program. And then for the remaining 9 months of the 12 months follow-up, the participants had to exercise independently. And so for people with dementia, it may be that in a residential care setting, you might choose to do group exercise, or you might try and maintain some sort of supervision throughout the exercise program. So this is another study. This is by Klaus Hauer's group from Germany, and this group has published a number of papers looking at the short-term benefits of a progressive resistance and functional training program, but this manuscript is actually one that has 12 months follow-up, and they do actually report on falls data. So it was a double-blinded randomised control trial of 91 participants. They recruited them after a stay in aged care rehabilitation, predominantly, but also from a community nurse. And so this may have impacted, I guess we just have to keep that in mind in terms of looking at the results. They're not a stable community-based population, so it may have impacted on their study findings. And they're also a fairly mobile bunch. I work in aged care rehabilitation, and not many of my patients can walk 10 metres unaided. And there was generally 82-year-old females, predominantly community dwelling, and they were relatively mildly impaired if you use the mini-mental. As I said, the intervention was a progressive resistance and functional training program, and the functional training program included balance activities. And it was 3 months, 2 hours, twice weekly. And it was group-based, so it was small groups of 4 to 6, and it was supervised by a qualified instructor. Their control was a fairly similar sort of routine. It was 3 months, but it was only 1 hour. It was twice weekly, and they did placebo motor activities. So they did things like flexibility exercises as well as chair-based exercises. And their primary outcome measures were 1 RM seated leg press, and also the 5 repetition sit to stand was their functional outcome measure. And what you can see there, so T1 is baseline, T2 is 3 months, so after cessation of the training, T3 is at 6 months, so 3 months of no training, and then T4 is 12 months or 9 months after the training had stopped. And what you can see there is, for both their strength and their functional performance, there were improvements at the end of the program and then 3 months after the training had stopped. But for the functional outcome, there was actually improvement maintained at 12 months, so 9 months after the training had stopped. But there was no change in the fall outcomes. However, it's only a study with 91 participants. It wasn't powered to show a reduction in falls. So what I like to do with this study is take the good and not the not so good, and say that it's great that we can make improvements in cognitively impaired older people, but there needs to be larger randomised controlled trials done to see whether this actually translates into a reduction in falls and fall injury. So this is Jackie Wesson's paper, she's here somewhere, and a number of professors who you can see there, Professor Lindy Clemson, Prof Brodati, who you heard, Professor Stephen Lord, Jackie Close, Professor Laura Gitlin from the US, and I was the physio working on this pilot study. So in contrast to the last study, this was a home-based program. It was 3 months. It was community dwelling participants. We only had 22 participants because it was a feasibility study. It was individually tailored, occupational therapy and physiotherapy prescribed. There was exercise and home hazard reduction, and so we did strength and balance training. The Westmead Home Safety Assessment was used looking at home hazards, and it was carer-led and supervised. So it was modified to suit the participant's ability. So the occupational therapist, Jackie, completed the Allen's cognitive screen, and from this you get a measure of their functional cognition, and this is done doing a leather lacing task. And it gives you an idea as their functional cognition, and that way you can tailor the intervention to suit the individual. So an example, and I have to thank Jackie for the picture you can see of an example of the exercise sheet. So Jackie designed these and kindly gave me a copy. So we used real photos of people and we gave them simple instructions. Adherence was recorded at the bottom of the sheet, and we could alter it to suit the person's functional cognition. So this was the visit schedule. So there were 2 occupational therapy visits in the beginning, and that was to complete the Allen's cognitive screen as well as the home safety assessment, and then 4 other OT visits after that. And there was 2 physio visits in the second week so that we could allow for the functional cognitive screen to be completed. The first was to introduce the exercise, and the second was to ensure safety and technique was that the exercises were being performed well enough. And then there were 3 opportunities for upgrade after that. And then there were some telephone calls to try and encourage adherence during the latter part of the study. So some of the results, so it was feasible, acceptable and safe. We had very good adherence, so at the end of the program 73% were still exercising, and in terms of the home hazard reduction, a mean of 10 home hazard reduction recommendations were taken up, but 50% implemented 50% or more of the recommendations made by the occupational therapist. In terms of the intervention, there was a non-significant reduction in falls, and again, this was a pilot study, so it's not at all powered to show a reduction in falls, so we can't really take a lot of meaningful information away from it except to say that it's a feasible, safe and acceptable study. And there was also no significant change in the physical measures. So whether Again, it wasn't powered to show these changes, so a little bit more work needs to be done in this area. So I guess lessons learned from this particular study was there was also a non-significant trend towards there being an increase in carer burden with the intervention. So I guess we need to factor that in when we're looking at future studies. The exercise intensity and duration, so I didn't use weights with people, we used gravity doing sit-to-stands and step-ups, but using ankle weights as a possibility. Carer availability affected how many times a week some people could exercise. And also, I guess, dementia-specific experience is vital in terms of getting good data in doing baseline and reassessment tests. Physical assessment considerations, I guess what we need to do is also make sure that the types of physical assessments we're doing are sensitive to change in the particular population that we're using them in. The intervention needs to be flexible, so we need to allow for carer sickness, participant sickness, holidays, and also for looking flexibility in terms of the approach of the physiotherapy and occupational therapy visits, and also to integrate the physiotherapy and occupational therapy approach. So from that study, as I said, Professor Close has got a grant to do a large randomised controlled trial, and they're looking for 360 participants to see whether we can actually show an improvement in fall outcomes in this group of people. So there's a few changes that have been made based on the last study. So as I said, they're looking at more flexible approach in terms of the physiotherapy and OT intervention. We've always said that carers need to have a minimum of 3.5 hours contact per week, but included in the inclusion criteria is that the carers need to be able to supervise exercise a minimum of 3 times a week. But the goal is this time is to get people exercising 30 minutes up 6 times a week, so that increasing the intensity. So I guess future research. So I guess we can look at exercise as could be looked at on its own, as the same as home hazard reduction could be looked at as individual interventions, and the only reason I've listed exercise there is because of the 4 risk factors that we found. Cognitive training, so there is some evidence that cognitive training can work in people with mild cognitive impairment or early Alzheimer's disease in terms of improving ADL performance and those sorts of things, but there's no literature to say that that can reduce falls. Dual task training, so there is again some preliminary evidence that dual task training can improve dual task performance in people with dementia, but these studies need to be done in larger randomised control trials. Gait retraining, so in some work I haven't presented, we've shown that dual task gait and simple gait predicts falls in this group. Multifactorial interventions, so other factors could be looked at together in an intervention. I guess we just need to keep in mind that multifactorial interventions are often expensive. And then also dementia drugs. There's some preliminary work to show that things like Aricept or donepezil can improve gait performance in cognitively impaired older people. But again, we need to see larger randomised controlled trials, and these need to specifically look at fall outcomes. So until then, Prof Brodati touched on some of this, but until then we need to use a pragmatic approach and consider interventions that aren't necessarily affected by the degenerative processes associated with dementia. So things like osteoporosis management, medication rationalisation and stopping those centrally acting medications. Cataract extraction, there's no reason why cataract extraction, there should be any difference in cognitively impaired to cognitively intact older people, except that I guess you'd want to watch for a delirium post-operatively. And I've put single lens glasses there for people who are community ambulant, but the question mark is the person's actually got to remember to wear them. Thank you.